Hey, good morning.
Good morning.
How are you doing today?
Doing great. Yeah.
Awesome. So, you know me, I know you, but for everyone who doesn't know you, can you tell us who you are?
Yeah, I'm Bruce Leewiwatanakul. I'm a child psychiatrist now at Oregon Health and Science University. I'm triple boarded just like you are, and you actually trained me, so that's fun. I did pediatrics first for 3 years and then went back to do adult and child psychiatry, combined at CHOP, and then got a job and loving my life as a child psychiatrist.
That's awesome. What made you even want to pursue medicine and then decide to choose to treat kids in kind of a pediatric setting?
Yeah, that's a long story. Medicine was something I've always kind of felt a kinship to in some ways. Wanted to help people feel like that gave me a sense of purpose in my life growing up and kind of aim for something as a kid, and then growing up in an Asian household.
I was going to say, what do you think gave you that sense of purpose, or what do you think inspired?
Probably my
someone?
mother.
Okay, great.
Saying like,
all good things come from your
you
mom.
you should do something that's going to be worthwhile, that you feel worthwhile about, something that you would feel good about in the long run and as you grow up and as you grow old. So I've always thought I was going to end up in medicine, or teaching was like my two goals. And I did dabble in becoming a teacher. And
Can you tell us about that?
yeah, I did a little internship during my college years when I had my little question of like, hey, where do I want to go? Taught math and science at a school nearby, UCLA, and loved it. But then I was like, you know what? I don't know if I could see myself doing this every single day right now, and that I should use my youthful energy to do something that is going to be like me on my feet a little bit longer, which I'll come back to because I think that's a funny story, that, you know, me being on my feet, because then I discovered I have very flat feet and then it hurts all the time to stand. But either way, medicine has always been something that I've really been drawn towards. And I found kids like always interesting to work with, and I enjoy being around people who make me feel younger. And you know, it's just fun, and it's different when you work with a family system. You get to do a lot of work with parents as well as like their siblings, and getting a sense of their home life, which I think has been the thread that I didn't see in the beginning. I don't have a lot of examples in terms of like people in medicine before me. So when I got into pediatrics, it was awesome. And I was like, this is kind of the realm that I wanted to be in, working with families and working with kids. And they seem to get so much better.
I was going to say, what do you think is the most awesome part of working with kids and working with families?
I think seeing them get better, you know, seeing that like you can try to affect change that's not so isolated and independent as like in an adult life would be, where they have to be more activated on their own to do things and engage in treatment. Whereas with kids, they might do that, and you have a set of people oftentimes to kind of help them through and help them engage in treatment. So I think having people who are really pushing your patients to get better is really rewarding.
Yeah, I think, you know, pediatrics, and it's not true for every kid or family that we see, but there's meant to be all these layers of support, and it's really nice when you can kind of align them and harness all of that support to help break that kid, that family, with whatever other system exists. And I think it can be really heartwarming when you see that happen, right? There can be so much fabric really uplifting them.
Yeah, for sure. And I think, you know, that the lack of support happens in every part of medicine, which is always the hardest part of medicine. But, you know, more often than not, there's always something that you can leverage in pediatric populations to get them more help, which makes our job more rewarding and a little easier to kind of search and find someone who could help and could help them get better. Yeah.
Okay, that's awesome. So I think you went into, you know, medicine because your mom is like, do something meaningful in your life, and so you thought about teaching, but then you realize then you have this love of working with kind of kids and families. They make you feel youthful. They'll always call you out. I feel like that's my favorite thing about kids, where if you try to say something too fancy or you're trying to say or talk about something you don't know about, they'll be like, you don't know what you're doing. And I think that part of it just keeps everything really real. And there's something about kids that just helps me feel at least more down to earth when I'm just doing my day-to-day job. I feel a little bit more just like I'm being myself, and not like I'm the persona of Dr. Sarah who's entering a room. Like I just, I'm a person who happens to have this training and expertise as I go forward.
Yeah, I feel like it allows us to have a personality that you can bring into the room and bounce off kids of different personalities as well. And, you fit better with some than others, but it gives you a lot of room to be yourself, like you said.
Yeah, and I think kids respond well to just you being curious about them and their lives. So even the kids who tell me things and I'm like, I don't even know what that is. They actually are amused when I'm like, I don't know what that is, but like, will you tell me more about that?
Yeah, I think that's that's the thread that I found when I was in pediatrics on how I ended up in psychiatry is I just end up loving to gossip with the kids that are coming into the hospital.
You like when they share the tea?
Yeah, I'm like, you're just yapping and I'm just gonna sit here at midnight listening. And it's interesting to hear their lives and why they end up in the hospital, whether it's for a physical illness or a mental illness. And that was the thing that kind of triggered a thought for me of like, hey, I like this part of learning about their lives and seeing like how they ended up somewhere. And that's kind of how I engaged in different rotations with psychiatrists at my hospital, and then found my way into psychiatry. And now I get to sit down.
I'm going to stop you for a second. So again, you entered and you did a peds residency, and I know you, so I know you even did a chief resident year after that. So it sounds like you were having these other experiences that made you wonder if, subsequent training in child psychiatry were really going to add on to your professional happiness. So can you tell me a little bit more about what some of those thoughts were?
I thought a lot about like longevity for myself of what I felt I could be most useful at and what I felt like I could be good at and what felt like society and the world that I was working in. Like I felt like there was a vacuum of a sort where, I was going through pediatrics training and I see this part of medicine in psychiatry and mental health that I just wasn't getting enough satisfaction out of in terms of my ability to care for them because I would be trying to help them and felt limited in what I could do and what I knew.
You were yearning for kind of more skills and really more knowledge to dig deeper in those cases.
Yeah, and I think I tried and was looking for ways to improve my general pediatric skill, and then I kind of just fell into more and more and looked for more and more. But thinking about like my career of like, hey, like where can I put my yapping skills to use? It ended up being a good fit for me, and being able to like actually dive into people's stories and felt like I was still doing medicine, felt like rewarding for me. And it's something I didn't know or think about before just because of a lack of exposure.
And I'll say a lot of people probably who are watching this don't know about even like the post-pediatric portal programs. So are you able to say how you heard about it and kind of why you decided to apply?
So the story is probably not as exciting as it is because I was Googling about like, should I switch to psychiatry as a pediatrician? And then it popped up that there was Post-Pediatric Portal program, which is a program that allows pediatricians who have finished pediatric residency to apply and engage in like a fellowship training. It's 3 years long where you do adult and child psychiatry combined. There are triple board programs that exist already, but this is kind of a way for folks to engage in postgraduate training after they've done their pediatrics. But having like mentors to kind of walk you through and engage in your skills and engage in things that they support you in, which is like for me, the interest in mental health really kind of just, got my boat on the other side of the river and was able to kind of land appropriately in training.
That's awesome. We're very glad you applied. I remember you actually submitted a very late application, but we're glad that you did.
My Googling didn't take me there before, right?
Hopefully people's AI metrics are working a little bit faster now.
There wasn't AI back then for me. Yeah.
Out of curiosity, do you identify as a pediatrician or as a child psychiatrist?
I identify as both. I say now I'm a child psychiatrist because I think it's easier for me to explain what I do that way. But I really still see a big part of myself as a pediatrician still, and I still talk to my friends about pediatrics topic. I'm still boarded.
I know, it's like we still maintain our boards.
We still maintain our boards.
I will say, I think I also identify as both, and it might be in different settings. And sometimes I say I identify as a pediatrician who happens to also be trained as a child psychiatrist, or who clinically does child psychiatry. Because I think, or I guess let me ask you, how does your very formal pediatrics background change your approach to child psychiatry?
That's a interesting question. I think I approach it in a much more systematic way in the ways that I think about mental health treatment and diagnosis, where pediatrics is full of algorithms so that we limit our errors, essentially, because our errors are kind of grave if there is one. We don't want to make those as much as we can. And in pediatrics and applying that to child psychiatry, it allows me to think about things in a much more broad way, but also systematically able to get to a diagnosis and treatment. I think it gives me a sense of courage and also in treatment. I think we see a lot of bad situations in physical medicine and bad luck in people, and it gives you a pretty different sense of how treatment can go well and treatment can go not so well. That's outside of our control. So I think it's really given me a different perspective on how I approach illness in general.
Yeah. And I think, the heart of pediatrics, so much of it has been kind of prevention. And really, can we enable kids and families to engage in healthy behaviors and healthy practices to help keep them, healthy, prevent them from getting ill? Whereas child psychiatry, right, all of the training is illness model. And so I think kind of the having of the both helps, I think you and I and others really think about what is the way we prevent some of the kids and the families that we see from experiencing, some of the mental health illnesses and tragedies that we see coming.
Yeah, we learn about anticipatory guidance in pediatrics from the get-go, right? We talk about safety and drowning prevention, helmets, car seats, all that type of stuff. And we do engage in a lot of mental health anticipatory guidance as well, but maybe not as in-depth as now I understand from the psychiatry side, but we still talk about those things, right? We talk about safety and sharps and stuff like that, and gun violence and gun prevention in terms of accidents. So yeah, it's given it a different framework, and it's not so new for us to talk about prevention when you're coming from pediatrics into child psychiatry.
Yeah, no, awesome. I think it is just such an interesting lens to kind of have the training in the both, and to see from that perspective. I guess jumping forward to now, you obviously are part of the TNT, Child and Adolescent Psychiatry Fellowship. So I think what made you excited to want to help teach primary care pediatric providers some of what you went through a whole other fellowship to learn?
Yeah, I think I didn't know that. Let me reframe that. I think it's always interesting what you learn about yourself from a retrospective look, right? When you jump in, you're like, this sounds like an exciting opportunity, but it sounds like an opportunity I wasn't necessarily looking out for, but it just kind of ended up being a fit. And you pulled me into it, which I think you can see that it's a fit, right? It's a thread that I had in pediatrics, and why I ended up in child psychiatry was I wanted to expand my own abilities in general pediatrics to be able to do more, and to be able to do of a more complete care. I am a DO, so I've been trained to think about things holistically, and that was always a piece that felt separate, mental health and physical health, and be able to expand my own skill level has been something I cared about and I wanted to do, and I saw that medical education for pediatrics was missing that part, which doing the TNT fellowship is exactly filling that gap as well, and doing it for the other folks who are also interested in doing the same, and saving them a couple years of extra training as well.
Awesome. And then I know at your institution, you're also doing some collaborative care. So again, for people who don't even know what that is or have heard of it but don't actually know what it means, are you able to kind of help us understand what is collaborative care?
Yeah, so I do integrated and collaborative care, which is a big part of my job now. The umbrella term of integrated care is just having mental health and physical health in the same medical home, essentially, and there are different levels of engagement with the psychiatrist and the pediatrician or primary care provider. In the integrated sense, there are very many different models that we don't have to get into, but collaborative care specifically is more a population-based approach where you're looking over a set of kids, in this case, where you're helping a behavioral health care manager take a look at kids who have mild to moderate mental health problems, and they kind of get managed proactively before they become more severe or engage in like self-harming behaviors or to the point where they might need higher levels of care. So we tend to act a little bit more proactively and reach out, getting them engaged in treatment. We work with the primary care providers in making medication adjustments and recommendations so that we're taking some of that load off of providers ahead of time so that they're not reacting to a crisis when the kids are coming in or reacting to when kids are really needing help, but more so that we're keeping tabs of a bunch of kids and helping them manage their mental health and let the providers know what's going on so that their loads are just not increasing in more ill kids. So collaborative care is somewhat new in terms of it being that kind of model, and there's still a lot of work to be done to make that readily available for more folks in the medical community.
And can you talk about what you think is going well with kind of the current collaborative care models? And then my question to you after that is going to be, where do you think, if you had a magic wand, like what would be the room to improve or grow?
I think a lot of things are going well in collaborative care in general. I think the thing that has been improving over the last times that I've been practicing is that screening and catching kids early has become much more common and much more easily done. And that's, primary care providers have done a great job at increasing their screenings and catching things prior to them becoming bad. But as we know in the COVID times, like our mental health in children have just become a crisis, and there aren't enough resources to actually help them. So what's going well is that we've been able to expand the ability to start treatment in children faster and earlier so that hopefully we are preventing things from being worse than they are. So that's for sure going well, and we're getting more data to support our work as well.
That's amazing. And I want to specify, actually, when you say we're starting treatment earlier, what do you mean by the word? Because I think when people think treatment, they maybe make assumptions about what that means. But what does treatment look like?
Yeah, so with collaborative care model, we rely on behavioral health care managers, which are usually master's level providers and up, who are able to do therapy and should be doing therapy. And they consult with a psychiatrist as well, who can kind of look over medication management. Primarily, engaging in treatment means like psychotherapy and getting them touch points with providers who are able to talk about mental health care, who may just end up having more time so that we're not relying solely on the PCP to be able to manage all of that. And that if medications are indicated, we would recommend that as well. But ultimately, it's up to the primary care provider and the patient and the family to decide if medications are right for them. But they engage in this proactive treatment for a period of time, and then they are kind of either graduate into back to the PCP care, or they might need longer term psychiatric help, and that's what we help them with as well.
No, thank you for elaborating. And again, I feel like there's some, people have their own, like I said, assumptions about what treatment means. And even when people think of, I think a lot of them do assume that it means medications. And then even when you add, well, it could be therapy. People have seen movies where therapy is, an adult lying on a couch talking about their dreams to someone. But again, what is therapeutic can look very differently. I just gave a lecture where I'm like, making sure someone's getting up, getting out of bed, taking a shower, eating breakfast with their family. That's behavioral activation, right?
That's
that
right.
can be the beginning of cognitive behavioral therapy, but people may not think that is therapy.
It's definitely therapy, and I think therapy in pediatric population is so different than therapy for adults. Oftentimes kids have big reactions to everyday situations just because of that's who they are and that's how they're built. What we are seeing in collaborative care is that we don't need long-term amounts of like therapy for them to feel better. And we mostly focus on like motivation, behavior activation, and just basic cognitive work in terms of like, you know, where your thoughts are kind of stuck at, and then how do we get you out of that pattern. So oftentimes we're not doing intensive therapy. It's like very brief, very easily done by a lot of medical providers as well.
Often very action oriented, like working on your sleep, limiting screen time, engaging in positive family experiences so that everyone can regulate with their big emotions. And parents learn how to model that for their children.
If providers, medical providers are able to have more time, I think they're all equipped with skills to be able to do those things as well. You know, just imagine a whole appointment as like anticipatory guidance. That's a lot of activation that they're talking about. So oftentimes therapy is quite brief, and they're able to just do that in a few sessions or a couple months, and they tend to improve over that time. And then if they don't, we talk about what else we can do.
Awesome. Thank you for really elaborating on that. And again, I think it's become something that's become more mystical with time. And it's so bizarre to me for people who are not in mental health. But do you think everyone needs therapy? And I'm like, yes. Like I could use more help with my sleep and, you know, getting off of my phone more and spending more time going on walks outside with my family. And again, those are some of the basic building blocks of how we begin when we talk about, you know, therapeutic things that could be helpful. And again, what it looks like for a kid or a teenager might be very different than, you know, for certain adults. But I think that's often where we're starting, and people don't realize that often like those everyday common sense types of things are the things we are initially working on.
And I think parents tend to apply what they know, which is for themselves as an adult, is to do things differently and just like, you know, think differently. But that's often not something that most pediatric patients have the skill to do, and that they have to, you know, be reminded that where kids' developmental levels are and what they need, which are much more basic than we hope for or that we expected them to be.
Awesome. Yeah, I do think as the world gets busier, I sometimes feel that like kids just don't get the opportunity to just be kids and do normal kid things. And again, parents don't necessarily have the time or the resources to then be with their kids as they allow their kids to do kid things. So sometimes it's just a shift in that, can we get this focus back to that? I think the world's just busier, and there's a lot more pulling on our attention at all times. And, you know, we aren't as present with our families and the people in front of us as much as we used to be. As much as we'd like to be. And it's so funny because I feel like everyone's like, oh, I should pull back. And then you're like, okay, well, what's keeping you from doing that?
So many other things.
So many other things.
It's hard to find the time to be able to commit to getting us feeling present and feeling better about things.
And then it sounds like there's a lot that's going well. If you had a magic wand, and you could say, here's where I would love to see, you know, integrative collaborative care go in the next 5 years, 10 years, what would that look like for you?
I think, you know, the best thing that could happen to collaborative and integrated care is an investment in doing more integrated and collaborative care. I think it's harder to work in a pediatric population in this model, and at my institution where I do collaborative care, you know, we have the opportunity to see a bunch of clinics start at the same time, both adult and pediatric. And what we're able to see is that the engagement from a pediatric population is harder to measure. They're, you know, kind of bound by school and a parent's schedule, and not just the parent's schedule and getting care for themselves. So there are more constraints on their ability to engage. And then there's like issues with confidentiality and engaging with a teen who is just, you know, a teen. So there are different challenges that come, and I think it takes more time and investment from the world at large in getting our kids' mental health to improve. So I think if things are going to be better, it needs like true investment from multiple stakeholders, both financial as well as like interest, right? And I think more data to drive these things. So I wish there would be more people who are engaging in this work so that we can produce more reliable data about how this can work well. what I am seeing is hopefully that we're able to increase our ability to address more than just anxiety and depression in this model, because a lot of what is happening is aggression that we're seeing, as well as a lot of parental concerns about how their kids are behaving. So it's more behavior management that we do need more help with as well. But expanding to that is a big task. And that's something that I hope we can end up doing in the future to be able to support that. But we need more skilled workers who can support that.
Yeah, no, I would love that. If you had, maybe there's a stakeholder watching this video, or, this gets forwarded to them, what would your plea, I guess, who are the stakeholder you were thinking of, and what would your plea to them be?
Everyone, I guess. I think everyone should pay attention to what's going on in our kids' lives and the young people of our lives in the world, because they need support, and that they need someone to pay attention and how things are affecting them. And that it feels like we're kind of trucking along, but there are simmering signs that people aren't doing so well, and that kids are struggling. School's getting harder. Families are struggling. The world is struggling. School's getting harder. Kids aren't attending school as much as they should. They end up at home to some degree doing online schooling, and they're limiting their social interactions. So there's a lot of things that are happening. So I just would ask everyone to pay attention to what's going on and seeing how they can help. Government and state issues and federal issues, they can definitely be able to commit to some investment in training more pediatricians to be better equipped at handling mental health concerns and increasing our ability to, do more with less.
Yeah, no, that was beautifully stated. Thank you. And then my last question for you is, you became a doctor, you became a pediatrician, you chose to then also become an adult and child and adolescent psychiatrist. What kind of drives you to continue doing the education work, the collaborative care work, the direct clinical work that you are doing?
I think the drive for me to keep doing what I'm doing is to pass on my own efforts, right? It's I wish that the work will continue and that the world continues to get better, and that I am able to pass on my own knowledge and things that I've learned and things that I've worked for. I think just seeing that I can leave something tangible behind and affect people's lives, even if they forget my name in 10 years, I think, I hopefully have taught my patients something and other people that I've trained with something, so that it sticks with them somehow, and they're like, who was that guy that told me something? I think just knowing that I can leave something behind to make the place better for other people is probably what drives me. I mean, I don't think about it, but now that you're making me think about it, that's where I think I get it from.
Going back to your mom saying make a difference. Well,
Mommy knows.
Mommy knows. Dr. Leewiwatanakul, it's a name we will not forget 10 years later, absolutely. Thank you so much for taking time to talk with us today.
Thank you, Dr. Arshad.